Welcome back to Brava Academy. In part two, Dr. Hessam Rahimi continues his discussion of independent tooth movement mechanics. All right, Dr. Rahimi, take it away.
Okay. Now continuing on this continuation of from part one. One other thing that is missing from the conversation amongst in our specialty is the concept of efficiency. I mean, historically speaking, we have always seen all these great cases and case reports and, over the years, over generations, basically. But we have never introduced treatment efficiency as a marker of success or failure. For example, if a case is taking 4 years and then comparing to achieving to the same goal in a matter of a year, is that really better? And if it has never been a metric in a measuring success, we've always only focused on malocclusion. But I think with the advent of all these customized systems, the new technologies, digital orthodontics, I think treatment efficiency is also an important metric that will help us decide which technology is better for our patients. As I go through these presentations, as you can see, like some of these timelines doesn't add up comparing to our experiences. But again, it's not magic. It's just the fact that the appliance is moving the teeth differently. It's grabbing that one tooth and it's giving it all the forces it needs to move from point A to point B. The moment that arm is attached behind the tooth, it twists and twerks and rotates and moves all the way to its final destination. It just saves us time. But how to, along the way, we cannot just be silent observers. We have to monitor and look at the case and evaluate to see what's going on. I tell you the standards that I follow in our clinic that helps me pinpoint and intervene to maximize that efficiency for my patients. And then hopefully you can do yours at your own clinic the way you find fit. But what I can tell you that every single little detail matters. It starts from your consultation visit, how you educate your patients, how you manage their expectations. Then it comes to your diagnosis and treatment planning. The way you take your records, the good quality records, determines the success and failure. It's a lot of times that people ask me for my opinion about their cases. And then I'm like, well, and even myself, like I look at an older case and I look, well, why didn't this part of it work quite right? And then I go back to the digital simulation and I notice that, I missed something myself. And then it wasn't the appliance's fault. It was actually my fault. However, because we are in conventional orthodontics, we are used to trial and error in order to achieve our goals. There is a re-education involved here that we have to know that there is no trial and error with this kind of technology. You have to be as straight so this is orthodontics on steroids. You have to measure up. You have to do your homework. Every little detail matters. The way you're taking that scan, your x-rays, your treatment planning, your engagement, your bonding, and then your case supervision and the decisions you make along the way, they have to be all excellent in order for you to be successful. But if you do that, the rest is easy. So I'm going to start with the consult visit. And you're talking the first time with the patient and introducing them this technology to you. You want to be clear and direct with them and talk about what this kind of an orthodontic appliance, the benefits and the problems that is associated with it. You want to be clear with them up front. You want to promise this and deliver more. You want to tell them about the initial discomfort. There's going to be discomfort involved at first because your tongue has to get used to it. And as a matter of fact, it's not the teeth that feel unusual sensitivity. The issue sensitivity is probably, based on my patients, less than regular braces. But it's the tongue that is the problem, and they has to get used to it. I have adults that don't feel nothing. Kids almost never report problems. Adults, some of them do, some of them don't, but you want to be upfront with them. And you want to talk about independent tooth movement characteristics, because at the end of the day, you're moving each tooth individually. So some of them, they can have different rates of tooth movement. So you might see spaces open up in areas that never existed before. You might see teeth that look straight, might look a little bit like angled along the way as during the course of treatment. You have to be upfront with your patients. You have to tell them that. And so this is how I use Brava in my office. Brava is uh, works hand in hand with aligners. So basically, I see it as an excellent appliance that takes care of 95% of the problems, all the hard aligner problems in a very short, efficient way. And I always want, not that always, but most of the time, I go ahead and at the end of treatment, I subject my patients to a couple of aligners because I've noticed that when it comes to tiny movements with a night eye, you lose that range of activation, and then the appliance to make that little final tiny movement at the end of the tooth movement, it doesn't have enough force. You can still wait. You can ask for a refinement, a second Brava. It doesn't make sense. If it gets to a certain limit, just like the case I showed you in the previous section, if it's if something you can do with a few aligners, just go ahead and take Brava out, leave the brackets on, scan, and then do it with a 2-3 aligners. And then if the patient comes next time and they didn't wear aligners, they were not compliant, you can go ahead and scan and ask for a refinement. But 99 out of 100, because you're going to tell them that if you do a good job and wear these 2 or 3 aligners at the end of treatment religiously, next time you come in, the brackets also come off. I'm only using these brackets as fail-safe, so that in case you don't wear it, I have a way to, use another Brava to do it. And then this always, almost all the time, guarantees their excellent compliance to take them through that last 5% of the way. You have to tell them that although all the attachments are on the inside and it's truly invisible, sometimes you need to wear rubber bands for the bite. You need to be aware of that. And then especially in extraction cases, there comes a time that you might see tipping of the posterior teeth. I have the next case I have selected actually shows that. You want to tell them up front that if I see that happen, I'm going to put brackets in the back, but it's going to stay in the back side of the mouth. Based on my personal experience, as long as we don't get to the 2s and 3s, they're fine. As long as we have told them ahead of time. And then you obviously want to tell them how to maintain their hygiene. So when it comes to case submission, you want to make sure records are accurate. You capture the proper bite in your scan, in your photos. You have good quality X-ray, they haven't moved. And if it's bad, if you haven't scanned all the areas, you have to repeat it. It's better to do it now versus dealing with a bad treatment plan. And then if you're really doing major tooth movement, like more than 3-4 millimeters, definitely go ahead and submit with a CBCT scan. It guarantees excellent treatment planning because you're able to see the position of the bone, where you start, and then so you know that whatever tooth movement you're doing, you're not violating that boundary. You also have the information of the roots, of the size of the roots, the volume of the roots, which helps the software to create a better, more predictable system. You don't want to overcorrect when you're treatment planning. Perhaps the only overcorrection I have is maybe the 0.1 IPRs that I don't do, and that's just for the sake of making sure, minimizing the chances of independent spaces opening. Go after all your board standards. They do a good job of aligning the teeth initially, but you want to make sure that your marginal ridges are level, your roots are parallel, rotations are pretty much corrected, the torques are right. Why? Because it's very likely that when you're done with the treatment, or when you go through the treatment, and when you take your final records and you notice something is off, it's because you didn't treatment plan right. So it's very likely that you get what you basically cook. And then the Brava is a technology that has one specific feature that it doesn't exist in another system, period. It determines between what the appliance can actually achieve versus where you're putting the teeth. So they have kind of reverse engineered the tooth movement in a way that, for example, let me give you an example, the best way to explain this. Let's say you want to retract an anterior tooth 6 millimeters. But if you go ahead and do that, you're banking your anchorage, you're taxing the anchorage, and it's going to lead to the molars coming forward 2 millimeters of the way. So it's impossible for the appliance to move back distalize 6 millimeters. In the software shows you that. So when you go ahead and play with the bars in the software, there's two bars. One is what Brava can do, and the second one is the auxiliary movement. You can treatment plan 6 millimeters of distalization in the anterior segment, but when you put the Brava movement at maximum and auxiliary movement at minimum, you're still going to have a 2 millimeter overjet. Basically, it's not going to move back the entire two, and then you are responsible for making that 2 millimeter extra movement more than the anchorage value that you had available based on the number of teeth, based on root surface areas, all that good stuff. And this system is able to tell you that. So one of the things I look at when I'm treatment planning, I maximize Brava and I minimize auxiliary movement. If it makes sense, and I can see that from this point, I can go ahead and take it all the way to my elimination of overjet. That's a valuable treatment plan, viable treatment plan. If not, then maybe I should extract, or maybe I should go ahead and switch my treatment plan to an extraction, or maybe use TAD to make the distalization happen. So this is a very important tool that only this technology has that needs to be considered. Appliance is fully customized, so make sure to take advantage of that. You can move teeth in grooves, you can do force modifications if you want to. And then sometimes I told you that if there's too much tooth movement, you can do them in stages. Probably the one rule you want to follow if you're thinking about using this system is taking good photos. Every visit the patient comes back, you will have to, I don't even see the patient until the photos are in my software, because this is not your trial and error orthodontics. This is your straight shooter orthodontics. You want to know if the journey every single one of those teeth have taken since last time. It's impossible to do it without comparing it to the previous visit. So you want to go ahead and load the photos and then go back and forth to see, because you have to make certain decisions along the way. And without photos, it's impossible. It's standard in my practice that every patient that comes in, we check all the contacts with a floss. If it's too tight, we run a strip to make sure there's no friction between contacts, because contacts means friction, friction means slower tooth movement. Again, we are orthodontics on steroids. Every little detail matters. The worst thing that can happen with IPRing more than we need to is we're left with a hairline space here and there. What is the easiest thing to do with aligners is to close hairline spaces with aligners. You want to decide, look at your anchorage requirements. You look at every single one of the teeth. If there is a way to help your biomechanics with elastics and attachments, go ahead and do so. Don't wait for the appliance to do it for you. Again, you're doing orthodontics on steroids. Check every tooth, check every bracket. If it's broken, if an arm is broken, order a replacement through the website. If the bracket's broken, rebond it. Every little detail matters. When you exclude a tooth from the equation, you're playing with the estimated anchorage values of the system. So one thing that comes to my mind is Brava that goes from 4 to 4 or 5 to 5 is less predictable than a Brava that goes from 7 to 7. The more anchorage values, the more anchorage you have for every single one of those tooth movements, the more that tooth follows does what it's supposed to be doing. Can we overpower Brava? Absolutely. We can, let's say, if you put a nitride coil to a canine or a strong power chain to a canine on the buccal side from a TAD to the canine, for example, you are going to see the same effects if you have used motion distalizer, carrier motion distalizer. You notice that when the patient wear those, you see the canines tipping distally and somewhat buccally, and then you see that over there. And this can happen with Brava as well. I have a slide to show you what to do with it right now. But you also, let's say you have an extraction space, then did the extraction. The buccal plate is now collapsed or non-existent. So don't forget, Brava is a light force system. The maximum force it applies to teeth is nothing more than what we apply 014 to 018 nighttime. So when it hits a stop, it's not that root is not going to follow as good as it's supposed to. So it can allow teeth to tip. If the patient has a severe tongue thrust and you're wanting to close spaces, well, I mean, if it's too severe, you can overpower the system and not let it properly close the space. I've had cases that I put a bite block on one tooth, the other side fell, and then that one tooth I noticed that had an intrusion. So that can happen. But like none of these is something to worry about. Like if, let's say in the case of that intrusion, all you have to do is remove the bite block and give it a visit by the next time the tooth is where it's supposed to be. This is a case where the posterior tipping can happen. Again, I have already told the patient that this can happen. If this does happen, I go ahead and put some brackets on the outside. And this is a case that, adding the bracket and a wire will allow me to control it from both ends, helps me settle it and correct the tipping. When you see a patient comes back, you want to look at the photos and see if there's any way you can help your biomechanics, go ahead and do so. Like here, if a patient comes back to me like this, I want to put a bracket on the upper 4 and lower 4 and 6. Why? Because why not? If you can, again, like you have a very rotated premolar, I'm going to add a button on the buccal side to help it derotate, because why not? I mean, I can wait for this arm to derotate the tooth, which it will eventually, but if I can help biomechanics with elastics, that's a strategy that is always a good idea. When you're distalizing the buccal segment, this is what I wanted to show you. So what you go ahead and if the canine tips distally and a little bit buccally, all you do is you wait, you still continue your elastics until your premolars are in a class 1 relationship. After they're in a class 1 relationship, all you do is you remove the attachment from the canine and you move it to the, let's say, first premolar. A lot of times when the canine distally tips like that, the arch also bows, so you would see 1 or 2 premolars moving a little bit gingival. If they have also moved gingivally, you give the elastics a little bit of a class 2 vertical direction. So let's say instead of upper 4 to lower 7, you do upper 4 to lower 5, 6, for example. And then it extrudes the tooth and keeps it in the distal class 1 relationship. It's very easy because unlike motion distalizer, you're not just fixing the buccal segment with Brava. You're doing everything. Like every single rotation is happening at the same time. Your deep bite is getting corrected. All that stuff is happening at the same time. You have an overpowered tooth. So all you have to do is take the button from the overpowered tooth and then let the appliance, apply its force. And then you get maximum efficiency in that regard. And the problem is resolved. These are not my slides. My friend Dr. O from Thailand uses, these are his. He does power arms to minimize any kind of tipping when it comes to overpowering the system, but you can go ahead and do whatever you like, or this is how he uses TADS. If I use TADS with Brava, it's always indirect like this. I never put TADS on the lingual side. I never bolt the anchorage base to the arch. It's very complicated. When it comes to extraction cases, you want to give it a wide range of treatment because, you don't know how calcified the bone is, how dense your buccal plates are, is it in the way or not? So I always promise about 12 to 18 months with good compliance. In adults, the tipping of posteriors can happen. If your kid is a teenager, it's pretty much everything is a lot more lenient and predictable. And then if I want to tell them up front, if you see tipping of the teeth, you might put brackets on the buccal side. I always tell them that it allows me to put some closing mechanics, like power chains between buttons on the lingual side, on the buccal side, allows me to close the spaces faster. The patients always appreciate that. And then again, you want to always think how you can help your biomechanics with elastics. When it comes to finishing, again, we know that aligners are not very predictable when it comes to certain kind of tooth movements. For example, in expansion, we expand like 30% more, 40% more in order to achieve, what we have treatment planned. When it comes to deep bites, we want to finish in heavy posterior contacts. It's not very predictable. Rotating laterals is hard. You know, extrusions are hard with aligners. We know that we have all used aligners for years now. But what are the same movements that I told you about, like extrusion of laterals, for example, or rotating laterals, is the easiest thing you can do with Brava. Give it 4 months. Like no matter how rotated, how open or deep the bite is, give it like 2 visits, 3 visits tops. You're 80, 90, 95, 100% there. So um, I think use the smartest way of using this technology is again like doing all the hard or heavy lifting with Brava, and doing all the little easiest stuff, the tiny things with aligners. That gives you the maximum amount of efficiency. And by the way, when I say aligners, I'm talking 3, 4. I mean, usually 1 or 2 or 3, barely 4, sometimes 5. And you can even go as far as have them wear them every 5 days. Because one thing I've noticed, or 3 days if you want to, one thing I've noticed is that the teeth that have been already moved with the Brava Force system, which is of course basically the entire PDL is engaged in the process because you're rotating and tipping and torquing and moving at the same time. They track a lot better with plastic to the point that I think it's very similar to as if you've done corticotomy. So for a few weeks, though, it doesn't happen all the way to the end, but for a few weeks, you have that advantage. Um, and also, because at the end of the treatment, you're keeping those brackets on, normally speaking, when you are doing your aligner treatment, you can use those as giant attachments on the lingual side of the tooth that you normally can't put such a thing in a patient's mouth. And these are lingual patients; they're already used to a lot more of that, so that you're okay here. And then that gives you a very good mechanical advantage, and also a wild card. Uh, uh, what is it called in the Monopoly? The free card, free out of jail card. Yeah,
Get out of
uh,
jail free.
yeah, that card. Why? Because you've done it. You rely them to wear aligners, and they don't. They don't happen to be compliant. You can always go back and scan again and ask for another. You don't even have to scan again because you already have the scan. You just submit it to Brava platform, and in 2 weeks, 3 weeks, they'll send you another Brava refinement. So I think the match between aligners and Brava is a perfect match made in heaven. I have 5 minutes to do this case. So this is another case, and I'm going to finish with this. If you notice, she has a lot of crowding. She's constricted on that upper left side, frostbite in the front, procline teeth, slightly class 3. I mean, not class 3, class 1 actually, pretty much. But procline teeth, upper and lower. Deep bite, biplanar occlusion. So I treatment plan her for 4 premolar extraction, basically upper 4s and lower 4s. She got the extractions done. She got bonded. I told her to go ahead and remove the lower premolars because the tooth itself was on the way of bonding the canines properly. So I told her to take the teeth out, come in for bonding, and then we can go ahead and after that we can remove your upper premolars. I work with a general dentist at one of my offices, so it's very easy for me. So she came in, she got the Brava, and then I sent her to get the teeth pulled. This is in April of 2024. By June, she came back. She had already taken the top tooth out. One of the benefits of Brava is that you have the forces in the right direction. If you extract after, the moment you take the tooth out from the way within the next few weeks, you see a lot of tooth movement. So here's one of those cases. As you can see, the extraction spaces are pretty much cut down in half, or at least 1/3 of it is gone. I still don't have any arch coordination pretty much. We are just 2 months into treatment. My bite is opening up on that upper right side. It's normal. She's an adult. The posteriors are tipping forward because of the force of space closure. Oh, by the way, I don't know if you noticed, but that upper right six arm is broken. So I didn't pick it up here. She came back next. I'm sorry, I went backwards. She came back next month, and I noticed the breakage, and I had the second stage in there, so I went ahead and engaged the second one. And here, because of that broken bracket and basically mechanics of extraction in an adult, I noticed that that upper right side, I need more control. I'm experiencing tipping, so I went ahead and bonded a buccal segment to help me control the problem. In the meantime, if you notice, my lower spaces are pretty much like half or two-thirds closed. The rotations are almost there. I'm only 4 months into treatment. If this was a normal braces case, I would still be on an 014 NITI probably. But my upper for 3 to 3 are aligned. The patient is very happy. I go ahead and add the buccal segment. And then this is 5 months. She comes back a month later. Now she has broken that 7. But I have that tooth engaged with the buccal segment anyway, so I'm keeping my buccal segment in place, and I'm just waiting for Brava to do everything else. If you notice on the lower, my extraction spaces are gone. I'm dealing with slight crowding. The rotations are pretty much like 90% corrected. Leveling is it's getting there, but I'm still not where I want to be. I'm still waiting for the appliance to cook. That's the expression. So you want to let it cook. The moment that you don't see movement in your photo progress is when you want to make a decision whether you need a second Brava, whether you need I'll switch to aligners, or you're done and you can debond the case and call it. 7 months, I'm still waiting for it to think because things are moving. So my lower arch is looking better. My upper, I noticed that I need to help the open bite that has been created. That premolar has moved gingerly, so I add rubber bands for vertical elastics from upper 4 to lower 4 and 6, 4 and 6 in form of a triangle, only on the right side. I'm just waiting for things to align a little bit better. My cross bites are gone pretty much. My midline is still off though. This is 9 months into treatment. I'm still waiting for the appliance to work, but it looks like it has slowed down to some extent. I still have details at the bottom that is not being met. So what I'm going to do at this point is I scan the case for a refinement. All you do is remove Brava. Takes a minute. You do a quick scan, then you re-engage it. And then she's continuing to wear rubber bands from upper right 4 to lower 4 and 6. And then this is the x-ray. I take an x-ray as well when it comes to refinements. My overjet and overbite is proper. The tooth angulations seem to be corrected quite a bit. I don't see any major tipping anymore. Maybe a little bit on that upper right side, but pretty much still doing okay. This is the second Brava is now arrived. I go ahead and I'm 10 months into treatment. I go ahead and engage it. That's it. Maybe just take the old one out, put a new one in. And I always tell my patients, because the teeth have moved closer to their final destination, this is a lot more lightweight comparing to what you had before. And they're never going to experience that first few days of discomfort when it comes to these kind of transitions. So you have to make sure you're explaining that to them so they're not too worried. 11 months into treatment, I'm not into the years mark yet. And as you can see, things are looking a lot better. My midline is now only a millimeter off. Lower arch alignment rotations are corrected, but my tips are a little bit off. That open bite I had on the upper right side is pretty much gone. Things are looking good. And then 13 months, I'm just continuing with rubber bands. That's about it. Now I want my canine to be class 1. So I added an attachment on the canine, on that right canine for it to become class 1. What I'm doing at this point on that lower front area, I'm doing IPR, make more room for the tip of the teeth to correct. But my curve of speed is corrected. Everything looks to be cooking towards the final destination. 14 months into treatment, things are even better. My smile arc is established at this point. Lower arch is level. but still some details are left. I don't see this as, I mean, it's very close. You can decide at this point to switch to aligners or keep going, but I decided to keep going. I still have a millimeter of space distal to upper left canine as well that I'm waiting for it to close a little bit more. 16 months, same thing. I'm still waiting. The midline is slightly off. My canine is still not quite class 1. I noticed that I'm slightly class 2 on the left side as well, so I go ahead and add an elastic over there. So you just look at the photos and you make your decisions along the way. 17 months, at this point, I am where I think I can wrap it up with a liner. So I go ahead and remove the Brava, keep the brackets on. I have a broken bracket on that upper right too, which is fine. The tooth doesn't need much of a movement. I don't need to put it back on. I keep it in the box though. And then, everything looks good. I just go continue elastics for better settling, keep my buccal segment still on, and then do aligners. You just cut out that section basically when you're doing your aligners. And then patient comes back in October. I am 18 months into treatment, and then everything looks good. I'm class 1 canines. There's still a little bit of tooth movement in the lower anterior tooth that is not ideal. So I don't need the brackets for that anymore. I can go ahead and remove the brackets, polish the teeth. Patient is very happy, remove all the attachments. And then what I call is the super retainer or a settling retainer. All it is I scan. I make the ideal tooth movement in the mix. I make one retainer. It's made out of Essex that allows the teeth to kind of fall into place. This is the final X-ray after removing the expander. The brackets. As you can see, I was able to retrocline upper incisors about 14 degrees and lower ones. Remember how much crowding I had, how much, I did extract, but I was able to retrocline them 4 degrees. That's a very good level of control. Roots are parallel. There's no, adverse side effects to the teeth for the most part. And here you can see them side by side. Upper is before and lower is final. They look pretty much where we want it to be. And then here it is. The occlusals, you can see how much we have been able to expand and, correct the problem. One thing I want you to pay attention to is look at that lower right 7, the tip, the discrepancy in vertical, all that was corrected by Brava. I didn't have any buccal segments there. So you can rely the appliance. But if you see that it's fault, let's say in this patient on that upper right side, it didn't have enough oomph to control the teeth, just add your brackets so you can control it better. But no, same patient, 3/4 were fine. One of them wasn't. It doesn't, and again, the younger the patient, the easier. You really have less and less worry about that. This is his smile arc, and this is how her profile changed. She had lip incompetence. That was taken care of. This is her final. Now, I don't like that upper right 4, but if you notice on my simulation, that one is also a little bit high. So yeah, I have to take blame on that to some extent. Yeah, that's all I have for you. I think I'm out of time. I have a lot of cases to show. Before and afters of the ones I've done with Brava. I'm open for questions at this point.
Thank you, Dr. Rahimi. That concludes part 2 of our webinar about the fundamentals of independent tooth movement mechanics. All Brava Academy webinars are recorded and made available on the BRIAS YouTube channel. Make sure to subscribe so you can be alerted when the next Brava Academy webinar is released.